Sir, you had a talk on tips and tricks in bifurcation stenting in the CSI this morning. So, sir, may I ask you what are the tips and tricks you are going to talk for the bifurcation stenting?
See, I always say that whenever you do a bifurcation stenting, you must strategize. So the first strategy that you put in place is whether you are going to do a single stent strategy or you are going to do a two stent strategy. In about 90% of the cases now, we do a single stent strategy because all the results, like the results from BBC1, Nordic, these various trials have proven that the single stent strategy has more benefits than the two stent strategy. As I say, keep it simple. However, there are certain situations in which you must go with the two stent strategy right from the beginning. For example, in a left main which is bifurcating into a large LAD in circumflex, and all the three vessels are involved. They call it Medina 111. And the disease in the circumflex is also quite significant and extending more than 10 millimeters beyond the ostium. There you would not like to take a chance and go with a single stent strategy, so you would go with a two stent strategy. I further say that beyond that, when you are doing a two stent strategy, you must already have in your mind a planned approach. Are you going to do a DK crush technique? Or are you going to do a culotte? Or are you going to do a tap? This should be clear in your mind right from the beginning. Right. However, when you are doing a single stent strategy, you should be clear in your mind that in certain cases where you have a large vessel, which is the daughter vessel or the side branch as we may call it, there may be a need to shift to the two stent strategy. So you've gone in with a single stent strategy, but you may need to shift. In that case, you must have your backup plan ready and you must have a lot of thought processes. So when you do this, you will be thinking, what sort of guide catheter am I going to use? For example, if you are going by the radial approach and you use a 6 French guide, then you are limited in the number of strategies that you can utilize. You cannot utilize, for example, a traditional crush technique because two stents will not go through the 6 French guide. So if you want to be, you need to use bigger equipment, then you must go with a 7 French guide catheter or an 8 French guide catheter. For example, if you use a 6 French guide catheter, the largest size of the rotablator burr that you may want to use so that you prepare the bed properly is only 1.5 millimeters. If you want to use a more than 1.5 millimeter burr size, you may need to use a 7 French guide catheter. So these are all points that you need to think. Tips are also related to the guide wires. What kind of guide wires should I use? Right. Should I use a hydrophilic wire or should I use a non-hydrophilic wire? Should I use wires which are easy to handle? I should not get them entangled. I usually tend to use 2 wires from 2 different companies so that they don't, on the table I can make out and one length is different from the other so that I don't get entangled. Right. So this is the other tip. The stent size, when you are using it into the parent vessel, it should come to the size of the distal portion, not the proximal portion. But the stent should have an expansion capability that the proximal portion can be dilated. Right, sir. Then you must be capable of doing what is called as a pot technique. So that the pot means that you do a short stent which is put in the proximal part of the artery. So this is an excellent kind of thing. You may also ask me, sir, what about imaging? Right. Is there any thing that is necessary for imaging the coronary artery besides the angiography? And I will tell you, yes, that in certain situations, especially in left main bifurcation, where we are talking about very large vessels and where we want to determine which strategy we want to take, then knowing the vessel from the inside is an extremely important part of the strategy. Right, sir. So these are the various points. And then you must be capable of handling all this and delivering the best results to your patients. Right, so there are many tips and tricks that are there and which we explain in the CSI,
Right, sir. So what are the spatial imaging techniques you follow, sir?
See, basically you use IVUS or you use OCT. OCT is not available all over, but IVUS is available in most places. IVUS is intravascular ultrasound, and so you can get an idea about the size of the vessel, you get an idea about the length of the lesion, you get an idea about the calcification of the lesion. So lots of things you are able to gather before you do the bifurcation. And after the bifurcation stenting, you can once again see the result on the IVUS, whether it is adequate or not, the stent struts are posed properly or not. All this information can be gathered on the IVUS.
Right.
So this is
And
the
sir,
imaging.
nowadays also it's called that the OCT is very important for the chances of stent thrombosis. So how frequently it's being done, sir?
OCT is being done in some centers, but it is more important for the bioabsorbable scaffold, not for the regular stent. For the regular stent, the IVUS is good enough. But for the biovascular scaffold, I think the OCT is better. Of course, OCT gives you better pictures than the IVUS.
Right.
But IVUS is good for bigger size vessels. If you have a 4O vessel or something, OCT may not see it properly. Similarly, calcification may not be seen as well by OCT as by IVUS. So there are plus points for IVUS and there are plus points. But pictures of OCT on the whole are more clear. It's like a black and white TV versus a colored TV. You know, that kind of comparison you can get between IVUS and OCT.
And so is there any preference on the stent, whether bare metal stent or drug-eluting stent?
See, today, actually, the Nordic study came and said that drug-eluting stent and bare metal stent, no difference. You may have read that.
Yes.
But in bifurcation stenting, I think it would make a difference. I think we should still stick to the drug-eluting stents. And we should use stents which have got a good access to the side branch. So that if we have to recross, when you have to recross to get into the side branch, the kind of side branch access should be adequate. Otherwise, you may have difficulty in doing the final kissing, which you need to do in many of the two stent techniques.
Right, sir. And sir, how do you see the prognosis in these patients who are having two stents rather than one stent?
They are slightly higher risk for stent thrombosis. They are slightly higher risk for the daughter vessel, or you call the side branch restenosis at the ostium. So therefore, the one stent technique is considered to be better. But in some cases, you have no choice. But you can sometimes do what is known as a final kissing without putting a stent in the side branch. So you can do a final kissing into the daughter vessel and with a kissing in the main branch, and you can avoid a stent in that situation, a second stent in that situation.
I think that was really very useful insights for the interventional cardiologist. So if I request you to summarize your talk, sir, in 2-3 key messages, what would be your key conclusion?
One is you got to be a good strategist.
Right, sir.
You cannot think after you start. You have to think first and then start. So you start with the process of either doing a single stent or a 2-stent strategy right up from the beginning. Mostly in 90 to 95% of cases, you may be able to do a single stent strategy and keep it simple. Just wiring the side branch and then maybe doing a kissing balloon at the end and avoid this 2-stent. But in certain cases, you may have to bail out from a single stent strategy because the side branch, which is fairly large, has got compromised. And when it gets compromised with a reduced less than TIMI3 flow, or there's a dissection flap over there, you may have to put a second stent. So you may have to have the capability of doing a reverse crush, or you may have to do a tap technique, what is called as provisional stenting of the side branch. And the second point that I want to make is that when you are directly going for a 2-stent strategy, again, you should be clear in your mind which of the 2-stent strategies I want to do. Whether I want to do a culotte, whether I want to do a DK crush, or whether I want to do a tap. That should be your clarity right up in the beginning. And you must not compromise at all on materials. Your material should be all available. NC balloon should be available, rotablator should be available, the scoring balloon should be available, and the flextome, which is called as the cutting balloon, should be available so that you can prepare the bed adequately before you take up these patients.
Right, sir. Thank you very much, sir.